Welcome to the Practice Pointers series. In this short video, we're going to talk about tips for handling the hemiplegic shoulder. We all know that the shoulder is a ball and socket joint, but I would like you to pause for a moment and think about that. What bones make up the ball and socket joint? Let's take a look. The bones that make up the ball and socket joint are the humerus in the upper arm as the ball, and the scapula or shoulder blade, which provides the socket. However, several other joints also make up the shoulder girdle. These include the attachments of the clavicle or collarbone. Firstly, the attachment of the collarbone to the shoulder blade here at the tip of your shoulder, and secondly, at the other end of the collarbone, where it attaches to the sternum or breastbone. Note then that the entire arm is only attached to the body by the collarbone's attachment at the sternum, making it almost free-floating on the body. For this reason, it has a very large degree of freedom of motion. Let's check the amount of movement that you have in your shoulder. I want you to raise your arm up behind your head and around in a full wide circle, and you'll see that the shoulder itself has a huge degree of movement or freedom of movement. Unlike other joints like the elbow that only moves in one direction and is held together by a strong connection of bones and ligaments, the shoulder itself is held together essentially only by soft tissue and muscle. But it's important for us to know how much movement occurs at the glenohumeral or ball and socket joint itself. So what I want you to do now is place your hand on your collarbone and don't let the collarbone or the shoulder blade move at all. Then try and move your arm in every direction, forward and sideways, and see how much movement you actually have there within the ball and socket joint itself. You'll see that it's a little bit less than 90 degrees or under shoulder height. And why is that? That's because the rest of the movement is happening at the shoulder girdle. So what I want you to do now is to raise your shoulder blades up, back, down, and forward, and see how much movement there is of the shoulder girdle itself. So it is important to note that less than 90 degrees of the shoulder's movement occurs at the ball and socket joint itself, and that movement beyond that must incorporate movement of the shoulder girdle. A low tone or flaccid shoulder and arm is common early after a stroke. The structure of the shoulder joint, being held together by soft tissues, primarily muscles which are now paralyzed, makes the ball and socket joint susceptible to subluxation and the shoulder blade immobile. Preventing subluxation is crucial in the early stages of stroke recovery and is a critical role for all team members. The consequences of shoulder subluxation include irreversible stretching of ligaments, tendons, and soft tissues, which can lead to instability at the joint and can hamper recovery. There is also a risk of traction injury to the nerves and blood vessels that run through the armpit, also called the brachial plexus neurovascular bundle. Therefore, the flaccid arm requires support in all positions. A sling can be used in standing, transferring, walking, basically whenever moving, and other supports such as pillows and lap trays can be used for positioning in sitting or lying. Note that whenever possible, it is best to have the hand away from the body, in sitting for example. This is because if the arm is positioned against the body, such as when the arm is in the sling for long periods of time, it may become stiff in that position, which will be extremely limited in function. Think of how many or what kinds of activities you can do with your arm in that position. Most of the ways in which we use the hand and arm require movement away from the body. For positioning in side lying on the unaffected side, first, shift the person to the far side of the bed prior to rolling onto that side. This will allow room for supporting the hemiplegic arm. Ensure the hemiplegic arm, including the shoulder blade, is forward and supported on pillows. This will protect the shoulder from damage and keep the arm in a good position. If the shoulder blade were to become stiff in position back beside the spine, it will hinder movement forward of the shoulder blade and limit function in the future. With your arm straight out in front, I want you to reach forward as far as you can without moving your trunk. Notice how much movement you have in that forward direction. Now take your shoulder blade and pull it back in against the spine. Often, when there's increased tone after a stroke, that's the position that the shoulder blade tends to assume. Can you feel how stiff and awkward that position might be? Careful positioning in lying can help to ensure that the range of movement of the shoulder blade is maintained. For side lying on the affected side, similarly, ensure the hemiplegic arm is forward, including the shoulder blade. The elbow is extended and the palm up. The unaffected arm should also be supported on a pillow, as should the top leg. When sitting in a chair, use a lap tray, arm trough, and/or pillow to support the affected arm. keep the affected arm in line with the thigh, helping this hand to be in a more functional position away from the body. Note: shoulder pain occurs more frequently in patients who are dependent for transfers. So whenever moving the low-tone arm, be gentle and protect it, especially during transfers. Avoid lifting through the axilla or armpit or pulling on the arm to move your client. Instead, grasp around the upper trunk near the shoulder blade to assist in moving the person. Whenever moving the flaccid arm, support both the upper arm and hand as illustrated here using what we call an arm wrestle type grip to support the hand. And remember, do not raise the arm above shoulder height in any direction. Remember why? Because we're only moving the arm at the ball and socket joint, and to move the arm any farther requires the shoulder blade to move also. And it is very difficult to move the shoulder blade passively. Lastly, when getting dressed, you will find that it is easier for the client to put the clothing item on the affected arm first, and for undressing, take it off of the affected arm last. I hope that you have found this practice pointer helpful. Should you have any questions, please contact the physiotherapist or occupational therapist on your team.